Now we will be moving from structural imaging to the functional imaging of the retina. So now I would like to introduce our next speaker, Dr. Chaitra Jaydev. She is a senior VR consultant from Narayan Nethralaya. She has got more than 100 publications to her credit, international publications. She is a great researcher as well as a clinician. And I would like to hand over I asked Dr. Chaitra Jaydev to deliver a talk on RFI and retinal oximetry and diabetic retinopathy. Over to you, Chaitra.
Yeah, thanks, Sunil, for this opportunity, and to AIOS. This is, I must say, a rather tough talk to do now because I have, we have done a lot of work on RFI and oximetry some time back, and as of now, because we have used Octa and it has come in a big way into our practice, we have, more or less stopped using these devices. But I will give you a brief overview of what we've done in the past and how it is probably a little different from using Octa. I have no financial disclosures. Now, coming to RFI itself, this is how the device looks. It's a non-invasive diagnostic approach for the measurement of retinal blood flow velocity. We can map the vascular network structures very similar to the Octa. And it also gives us information of the oximetry and the metabolic status of the retina. So overall, it's an in vivo, non-invasive imaging of both the retinal structure and of the function. So what we saw all along were imaging where we were able to actually see the morphology, but not clearly delineate the function as to whether the retina is functioning optimally. Is it able to give whatever else the functions that are required for good visual system here. So the RFI system has a fundus camera. It has a stroboscopic illumination, fast filter wheel, and an LED-based stimulus generator. Multiple snapshots of the retina are taken in less than 0.2 seconds. I will show you a video of that. And this high speed reduces interframe retinal motion, and it tracks the movement of the RBCs. So it uses multiple sequences, and it therefore creates a capillary perfusion map, and it performs also blood flow velocity measurements. Now, the other, or if you have to put it together, it gives us a non-invasive capillary perfusion map. We call it as the NCPM. It also gives us the velocity. It gives us the measurement of the oxygen saturation, and also gives us some information of the metabolic state. As far as I know, not too much inputs are there as far as the metabolic demand or the state of the retina goes. Even using the RFI, it's been rather difficult. So this is how the imaging comes across. This is the microcirculation or the NCPM map. This is the blood flow velocity. It gives us the quantification, the oximetry map, and finally the metabolic map. Now, this is something that we've studied the most, so I will be elaborating a little bit more. And Jay has done a lot of work using the RFI as well. So by directly tracking the movement of the RBCs, the RFI is able to create a map of the retinal microvasculature. And when studying this vasculature, we are comparing it with FFA. Witkin et al. Have shown us that RFI could visualize a higher order vessel branching, and also the FAZ was more clearly delineated, and it appeared to be much smaller when using the RFI. Going on to the flow velocity, under green illumination, the hemoglobin within the RBCs provide a natural high contrast chromophore. It therefore allows the RFI to track the movement of the individual RBCs through the 8 sequential images. Allows direct measurement of the distance traveled between the RBCs, and that divided by the time it takes to capture the series of images actually yields a measurement of the blood flow velocity. So if you can see the video here, rapid sequence 8 images are taken in less than 0.2 seconds, and therefore we are able to measure the blood flow velocity, and it gives an automatic quantification in millimeters per second. Going on to the oximetry that's there in the RFI, it uses a multispectral imaging mode, and it detects the differences between the absorption spectrum of oxyhemoglobin and deoxyhemoglobin in order to give us the difference and therefore determine the oxygenation. Accurate oxygen saturation maps may therefore help provide additional details in the pathophysiology of various diseases of the retina, especially vascular diseases, because we do know that there's a lot of ischemia here involved. Now, coming to the metabolic function, the retinal functional signal is studied by analyzing the reflectance changes in the retina after stimulating it with a visual stimulus. Such functional reflectance signals are small. They originate from activity-dependent metabolic, hemodynamic, and fast and slow light scattering changes that are seen. The difference between the post-stimulated and the pre-stimulated images reflects the metabolic state or demand and the functional state of the activated axons of the ganglion cells. Now, there are some studies about this. We have not done much. So based on the intensity flavor protein fluorescence in retinal tissues, it possesses potential for diabetic retinopathy screening and monitoring for progression and improvement. Field et al. Have shown that individuals with DR in at least one eye had significantly greater mitochondrial flavor protein autofluorescence activity than in diabetic patients without retinopathy in either eye. So overall, looking at the applications in diabetic retinopathy, it has definitely opened possibility for various disease pathologies associated with alterations in the blood flow, whether it is in the capillaries, arterioles, or venules, and different collateral vascular patterns in normal as well as diseased retina can help us actually compare using the RFI. We had written a brief review on the clinical application, and what we were able to see, especially in patients with DR, is the shunt and anastomotic vessels were very well delineated, and the NCPM especially was useful. It helped us detect and follow up avascular areas. It also helped in follow-up of abnormal vascular patterns, be it loops or neovascularizations, and it also helped in monitoring the effect of guided laser treatment. So here you can see the FAZ can be very well delineated on the NCPM in patients with NPDR. And when we compared it with FA, we were able to delineate the non-perfusion areas and neovascularization and telangiectatic vessels as well. Here again, comparison between FFA and RFI, you can see the neovascularization. Of course, the leakage is not seen on RFI as seen on FFA. The blood flow velocity helps in early monitoring of the progression of diabetic retinopathy and also the effect of treatment and guided laser treatment. So this was one study which showed that there was an increase in arterial and venous blood flow velocity in patients with early DM and with no DR as such. These findings support the notion that abnormalities in vessel function exist even before the development of structural changes. So function before structural changes. Retinal oximetry, other than an RFI, we also have a standalone oximetry device. It has been shown that oxygen saturation is increased in retinal arterioles and venules, and the oxygen saturation in retinal vessels in diabetic patients was found to be dependent on the severity and the type of the severity of the disease. So this is a study on the oximetry in patients with DR. They found that in eyes with DR, there was increased venular oxygen saturation and decreased AV difference compared to eyes without DR, suggesting an altered metabolic state as well. So like I said, there's a standalone device to measure the oximetry along with the RFI, and this is how it gives us the the saturation, the oxygenation across each of these blood vessels. One of our consultants who left recently has also completed his PhD on oximetry itself, and he has published the normative database, and it provides basically an Indian population to compare with previous studies, the age, the vessel diameter, all of it was studied in this. But the drawbacks that he found was that arterial saturation do tend to go above 100%, and the saturation values are different for disc-centered and quadrant-centered images. And the saturation does appear to be higher when the vessel diameter is smaller. So the last thing that I'd like to share was we had done a quick study between RFI and Octa because we're using Octa so much more, and we wanted to compare the non-invasive capillary perfusion maps and velocity measurements between RFI and Octa. We use the AngioView device. To give you a brief background, and non-invasive imaging is important because we need to keep repeating it. The adverse effects compared to systemic administration of contrast agents are well known. We need to visualize a microvascular architecture over a large area with maximum resolution, and quantifying blood flow may be the key to unlocking explanations for several conditions that are poorly understood. So we compared basically macular imaging on RFI with OptoView, and we had about 15 healthy normals that we had included in this study. So if you see the panel above and below, above is the NCPM map, the non-invasive capillary perfusion map, compared to the Octa below. You can see how comparable it is, and this is the mapping of the blood velocity. We did a comparison between image parameters and velocity parameters. What we saw that the RFI offers a wider field of view with a higher pixel resolution compared to AngioView, and since 35 degrees of the image gives a large field of view, 2 images are adequate to complete the image of the posterior pole with good resolution. And velocity parameters showed that the velocity in arterioles is higher than in venules. It also showed that velocity in larger arterioles is higher than in the smaller ones. So this is, closer comparison between the Octa and the RFI. So quickly to compare between the two, Octa definitely has the advantage of segmentation and depth, and it has lesser resolution, however, compared to the RFI. So the advantages of RFI are good image quality, wider field of view, but the limitations are it lacks depth resolved information, and it image acquisition is very, very difficult and compared to the Octa and even for the patient, because it has a very, very bright flash. Thank you, and I acknowledge the help of my colleague, Dr. Aditi, in preparing these slides.